Hello everyone. Today I'll be sharing a video regarding the optic capture of a broken lens. Sometimes this happens, especially when you are not prepared for such events. The patient had an intermittent cataract and a swollen lens. I always fill antechamber tightly with high viscosity viscoelastics to control the vertical vector, because unless you control the vertical vector, you can land up in a disaster and the patient may face Argentinian flag sign. Then I create all the side port incidents and the main clear corneal incident and fill the antechamber once again and make the so that you can make the antechamber capsule absolutely flatter. Now make a small nick at the center of capsule and do not try to extend it towards the mid periphery or periphery. Then with the utrata forceps through the main clear corneal incision, hold the nick and make a small rexus. Size hardly matters. The important thing is not to go towards the periphery, which is very crucial and important here. Now remove the viscoelastics with the more exposed tip. Try to aspirate the lenticular fibers and the fluid present in the capsule with the blunt and do it gently. Do not insert the tip inside the bag. Now with the blunt curved cannula, just massage the anticapsule gently. This step is crucial for breaking the loculi and bringing the capsular tags and the fluid towards the capsular opening, allowing them to easily ooze out from the small opening of the capsule. You can even flush some amount of fluid inside, but do not try to push more fluid in the bag, because this can again create either the tear of antecapsule or it may even tear the posterior capsule. So just do gentle swift movement to break the loculi and bring whatever you can you place it towards the center of the opening. Now fill the antechamber with high viscoelastics again, and because the lenticular pressure is now decompressed, make a small nick. Hold the nick with the trata forceps. Make a small nick, and with the trata forceps you can easily extend the capsular axis to the desired size, and you can easily extend the axis to desired. Sometimes the pressure remains high even after decompression, so do not try to attempt to go towards the periphery suddenly. Check to ensure the risk is minimal. Make small nicks again gradually, step by step, you can extend the capsular axis to the optimum size. Handling an intermittent cataract requires patience, as any uncontrolled step can create disasters. Your rexus can extend, and if you are not careful, performing phaco surgery with a compromised rexus can lead to significant problem. If you continue, having VR support is very important and crucial. In this case, there was a raised intraocular pressure in the antechamber and the pupil. You can see that there is a pupil constriction. I hydrated and performed hydrodissection and delineation very gently. Now I am ready. You can see there is a pupil is constricting, and again I filled with coated the endothelium with dispersive viscoelastics. Now I am ready to do fragmentation. Phaco fragmentation is not difficult here, because majority of the cases the cataracts are very soft and white. However, if the intraocular pressure is raised, you won't have sufficient space to work, and it can create a risk of catching posterior capsule during the phaco fragmentation. Therefore, proceed cautiously and carefully. In phaco fragmentation, because your phaco tip is sharp and active, you need to have a very active other hand. You can use any blunt instrument such as blunt chopper or Sinskey hook instead of a sharp chopper. You don't require sharp chopper here. And keep the phaco tip in the center, support the cortical and the nuclear fragments with the second instrument, and feed the instruments into the tip. So this process should be very gradual and under proper illumination and visualization. Now after completing phaco-fragmentation, the cortical matter is left behind. You can either extend the rexes here, but in this case I continue to remove the cortical matter through irrigation and aspiration. And for the posterior capsule polishing, normally I use a hydrojet technique where I push BSS with the blunt cannula and flush the fluid parallel to the posterior capsule. In the majority of the cases, this technique easily removes the fibers and cells present on the posterior capsule and from the equator of the bag as well. Now the eye is ready to receive the intraocular lens. Here I used a Clarion lens from Alcon. When I injected it, I realized that trailing haptic was broken. In this situation, I had a choice to remove the intraocular lens and implant another one. However, I decided to control my nerves because the patient could sense any anxiety. It's important to remain cautious and calm. Given the smaller axis, I thought about placing the eye lens in the way that smaller axis could provide some support to the optics. I started removing the viscoelastics and while simultaneously thinking through my options. In the meantime, I asked my staff to arrange another lens. Before the new lens arrived, I decided to try optic capture. Although this is typically done with the three-piece lenses, I had never attempted it with a single-piece lens before. However, since the Clarion lens from Alcon is relatively softer and hydrophobic implant and making it easy to cut and remove, so I was not very anxious here. I decided to try optic capture to stabilize the IOL optics. Achieving exactly centered optic is crucial for premium IOL to perform optimally good. So after several unsuccessful attempts, I finally tried manipulating the lens with all directions. I attempted several times, and for this I used two Sinsky manipulators to grab the optics of the lens and bring it to anterior to the anterior capsule. So I did it from in different areas to make it successful. So I did this. So now the part of the optic is anterior to the anterior in the capsular axis. Now in the different area also. This resulted in a good stabilization and perfectly centered IOL. To ensure the lens would stay in this position long term, I flushed the BSS slightly forcefully. The lens remained exactly in the same position without any change. Then I also performed the visco removal using IA tip, and fortunately the lens stayed perfectly in the place. Very next day, patient was having 6'9", very happy patient, and I was also very happy because the lens was exactly in the same position. And I asked the patient come after 6 months so that we can assess the centration of the lens. In case of decentration, we have choice to remove the lens and exchange the lens. And it happens several times. If you are cautious, careful, you can manage it. Thanks for watching.